Hey everybody, welcome back to these high-yield Step 1 questions. Be sure to like and subscribe if you find this is helpful. In this question, a 12-year-old girl is brought to the emergency department by her parents due to severe abdominal pain and vomiting that started 6 hours ago. She recently began treatment for non-Hodgkin's lymphoma. Physical exam reveals diffuse abdominal tenderness. Lab tests show elevated serum potassium level of 6.5 and a low serum calcium level of 7.2 and elevated serum creatinine of 2.2. An abdominal ultrasound indicates the presence of renal crystal deposits. Which of the following compounds most likely contributes to this renal pathology in this patient? All right, in order to answer this question, we have to understand what tumor lysis syndrome is. That's when massive numbers of tumor cells die super rapidly, typically after chemotherapy, in hematologic malignancies like non-Hodgkin lymphoma. And it spills their contents into the bloodstream. And this sudden flood overwhelms the body's homeostatic mechanisms, and it leads to a couple of things. The first one that you need to know is hyperkalemia. That's from the cell cytoplasm. Next is hyperphosphatemia. That's from the nucleic acids. Next is hypocalcemia, and that's due to the phosphate that binds to the calcium. And then there's hyperuricemia, and that's from the DNA breakdown. So that recent chemotherapy causes the rapid cell turnover, and then elevated potassium, low calcium, and elevated creatinine would be the electrocyte triad of tumor lysis syndrome. You get the renal crystal deposits on imaging, and non-Hodgkin's lymphoma means that there's a high tumor lysis risk. So uric acid is the byproduct of the nucleic acid metabolism. And at high concentrations and an acidic urine pH, it precipitates into the crystals and it damages the tubules. And so our answer of what's contributing to the renal pathology here is uric acid. So there's your bottom line. For our next question, and I know you just got a sneak peek there, but I'll show it again. A 30-year-old man presents with a 2-week history of increasingly bizarre behavior. He has been speaking about receiving secret messages through the radio. He's been neglecting personal hygiene, and he has stopped showing up to work. His medical history is significant for multiple psychiatric hospitalizations. First occurring when he was 22. He's unkempt, poor eye contact, speech is scant, and he says they might be listening. Which of the following is the diagnosis? This is pretty clearly going to be schizophrenia. And so the diagnosis for schizophrenia must include greater than 6 months duration. That's greater than or equal to 6 months duration, greater than or equal to 1 month of active phase symptoms. That's like delusions, hallucinations, disorganized speech, and negative symptoms. Also the functional decline. And the negative symptoms are more disabling and they're harder to treat than the positive symptoms. And the risk factors are family history, early cannabis use, and obstetric complications. The negative symptoms would be like restricted affect and scant speech, and then also the functional decline. And all of this meets the DSM-5's criteria for schizophrenia. It's not major depressive disorder with psychotic features because that's mood congruent delusions or hallucinations. Here, the psychosis isn't confined to periods of depression, so that's not the answer. Schizoaffective disorder, that'd be like psychotic symptoms and a mood episode. So that requires a concurrent mood episode of mania or depression with at least 2 weeks of psychosis without mood symptoms, and that's not demonstrated here. Definitely not OCD. There's just no evidence for that. That's intrusive ego-dystonic thoughts. And also compulsions. And this patient has fixed delusions. They're not obsessions or compulsions. There's no compulsive behaviors that are being described here. And paranoid personality disorder involves the pervasive distrust without psychosis. So that's not going to be it. The bottom line is schizophrenia is characterized by delusions, disorganized behavior, and negative symptoms persisting for at least 6 months. If you like this new format, please let me know by liking and subscribing. I'm always trying to improve. For the next practice question, during a research study, investigators observed that a certain virus has developed the capability to escape immune recognition by interfering with the host's antigen presentation system. Specifically, this virus downregulates the expression of class 1 MHC molecules on the surface of infected cells. A second variant of this virus, which lacks the ability to interfere with the MHC class 1 expression, is also studied. Which of the following components of the immune system is most likely to play a heightened role in combating the original virus rather than the variant virus? And you can see the answer is natural killer cells. Let's talk about why. So there are some viruses that actually shut down the MHC class 1 expression. They're trying to hide from the immune system. And normally CD8 positive cytotoxic T cells will patrol the infected cells by scanning for their MHC1 display. And if that display disappears, then we could have some problems, right? So the natural killer cells are the immune system's weapon when the viruses are trying to be really sneaky. So natural killer cells, these NKCs, are wired to do the opposite of CD8 positive T cells. They look for what is missing, not what is present. And so if you don't have an MHC1, then that's a red flag. And so they activate and release perforin and the granzyme B, and they kill the infected cell on the spot. And so in this question, the virus that downregulates the MHC can get away from the CD8 positive T cells, but not away from the natural killer cells. And that's why the immune component plays a heightened role against the original virus, and it's going to be natural killer cells. Okay, now why is it not the lymphocytes? Well, that would be like antibody production, right? The B cells target extracellular pathogens. They do not clear MHC1 deficient infected cells. What about CD4 positive T cells? Well, those would be MHC class 2 recognition cells. And remember, the 4 times 2 is equal to 8, and they always have to add up or multiply it to be 8. That's why 1 times the CD8 positives, and the MHC class 2s line up with the CD4 positives. It's not macrophages because that'd be phagocytosis, and those guys target the opsonized extracellular pathogens, not the intracellular viruses. And it's not neutrophils because that would be like bacterial infections and pus, and that's not involved in viral clearance. So the big takeaway here is that natural killer cells are super important for targeting virus-infected cells with downregulated MHC class 1 expression. The CD8 positive T lymphocytes induce apoptosis in cells that express class 1 MHC. And natural killers, they kill the guys that do not express class 1 MHC on the surface. Okay, in our next question, we have a 55-year-old woman presenting to her primary care physician, complaining of weakness in her right arm. She sustained a Colles fracture of her right wrist in a car accident 3 months ago. Then she had a cast, and when they removed it, she noticed her right forearm is significantly smaller than her left. Exam shows a 3 centimeter decrease in the circumference of the right forearm compared to the left, and decreased strength in the right hand. There is no tenderness, and sensory examination is normal. Which of the following is the most likely mechanism responsible for the observed difference in the muscle mass? Now, intuitively, we know that it's going to be smaller, right? And interestingly, you can lose up to 5% of your muscle mass per day during immobilization. So if you don't use it, then you lose it. So she has some problems with her forearm muscle loss after the cast was applied through a fracture. 3 months later, now her grip is super weak, but the sensation and the nerve function is totally intact. And so it's not a nerve injury. This is just diffuse atrophy. So when a muscle isn't used, the body shuts down the protein synthesis and it ramps up the protein breakdown using the ubiquitin proteasome system. And so that shrinks the muscle because it's no longer needed. And so the correct answer here is going to be the acceleration of the protein breakdown. That's our correct answer. Diminished acetylcholine release. That would be seen with something like myasthenia gravis. That would cause weakness, not atrophy with sensory loss or immobilization. What about increased expression of anabolic signaling? Well, that's like mTOR or IGF-1. That would promote hypertrophy, not shrinkage. What about inhibition of calcium reuptake into the sarcoplasmic reticulum? That's more like the circa pump and the prolonged contraction. So that would affect the contraction dynamics, but not really the long-term muscle size. What about enhanced production of the connective tissue factors? Well, that would lead to fibrosis, and that would cause stiffness and scarring, but not muscle mass reduction. So the bottom line here is diffuse atrophy from immobilization leads to decreased muscle mass and strength after the wrist fracture. In our next question, a 72-year-old man presents with shortness of breath and chest discomfort for the past month. He has a history of chronic obstructive pulmonary disease and hypertension. Physical exam reveals absent breath sounds on the right lower lung field and jugular venous distension. Lab tests show mild leukocytosis. A CT scan of the chest reveals a large mass in the right hemithorax invading the mediastinum and causing compression of adjacent structures. The mass appears to extend to the diaphragmatic surface of the right pleura. Which of the following structures is most likely affected due to the mass's location? All right, so this is going to be like an anatomy kind of pathology question. And you've got a right-sided thoracic mass, right, which is right here. You have mediastinal invasion and a diaphragmatic pleural involvement. So now we have to identify the structure that's vulnerable here. And the answer is the right phrenic nerve. And that travels anterior to the hilum of the right lung, and it courses alongside the right heart border, and it passes over the right pericardium, and it ends at the diaphragmatic surface of the pleura. And so a mass on the right lower hemithorax extending to the diaphragm and the mediastinum is in the perfect position to compress the right phrenic nerve. Now, the right phrenic nerve has its origin from the C3 to C5, the cervical plexus, and it's the motor for the diaphragm. 3, 4, 5 keeps the diaphragm alive. Also, sensory, you have the central diaphragm, mediastinal pleura, and the pericardium, and it runs anterior to the hilum, unlike the vagus, which is posterior to the hilum. The mass effects are, for the phrenic, it would be associated with diaphragmatic paralysis. You could see recurrent laryngeal problems like hoarseness. The azygos would have venous congestion, and the thoracic duct would be chylothorax. That'd be a left-sided issue, though. So the mass is on the right. It's compressing the mediastinum and the diaphragm, and so it's just going to be that phrenic nerve. Now, why is it not the left recurrent? That'd be vocal cord paralysis. What about the azygos? That's the posterior mediastinum. This mass is anterior and lateral. What about the thoracic duct? Well, that would be chylothorax and left-sided structures because the thoracic duct ascends on the left side. It's not near the right lower lung. What about the esophagus? There you'd have dysphagia and posterior mediastinum problems. So you get a big old bulky tumor on the right side of your lower chest and it presses against the mediastinum, the diaphragm. And by the way, the mediastinum is just that membranous partition between the two body cavities and the parts of the organ, especially between the lungs. And so what gets caught in the crossfire is that right phrenic nerve. It controls the right half of the diaphragm. And if you compress it, you get dyspnea, especially when you're lying flat. And especially with this patient who has underlying COPD. So the bottom line is you have a mass in the right hemithorax that is likely going to compress the right phrenic nerve, causing a diaphragmatic dysfunction. All right, here's a good high-yield practice question. A 55-year-old man comes to the clinic with a 3-week history of low-grade fever, fatigue, and unintentional weight loss. He recently underwent a dental cleaning, and he has a history of mitral valve prolapse. So this right here should already be cueing us in to our condition. It's subacute bacterial endocarditis. So don't be spooked by all these weird names. Basically, we have a heart murmur and a recent dental procedure, and then we get fatigue and we get fever and weight loss. And this is subacute bacterial endocarditis, and it's caused by that slow-growing bug from the mouth. So it's going to be Viridans group streptococci. And so those bugs, they really love hanging around the damaged valves. And in this case, it's going to be the Streptococcus sanguinis. That's the alpha hemolytic optochin resistant, commonly found in the dental plaque. And so anytime you have a dental cleaning, mitral valve prolapse, that should immediately cue you into Viridans strep. It's optochin resistant alpha hemolytic gram-positive coccus. Now, there are a lot of kind of freaky options here, but we can break them down one by one. A, that's associated with like GU instrumentation. It's a nosocomial infection, and that's not associated with dental procedures. Epidermitis, that'd be with prosthetic valves and catheters. Streptococcus pyogenes, that's a group A strep. You'd have pharyngitis and impetigo. And agalactiae would be the group B strep, and that's neonatal sepsis. So it's really mitral valve prolapse gives it away. It's going to be D. It's the one by elimination you can tell that that's the Viridans one. Subacute bacterial endocarditis, the Viridans strep. So the bottom line is optochin-resistant alpha hemolytic gram-positive cocci in a patient with mitral valve prolapse suggests infective endocarditis by Streptococcus sanguinis. There we go. Okay, in this question, a 29-year-old woman visits the clinic to discuss her options for contraception. She plans to pursue a high-stress career and is not considering children for at least another decade. Relatable. Her medical history is unremarkable and she has no known allergies. Her priority is a highly effective contraceptive method that requires minimal maintenance. After discussing the potential side effects of various methods, she is concerned about long-term impact of her fertility. Which of the following contraceptive methods has the greatest association with a potential delay in return to fertility after discontinuation? The answer, progestin-only injection. So that is a DMPA, is a progestin-only injection, and that provides long-term, highly effective contraception with minimal use effort. So it's super ideal for somebody like her. It's not recommended for those who are concerned about delayed return to fertility, though, because ovulation can take a couple of months to resume after discontinuation, and that's a known side effect that's not shared by IUDs or rings or barrier methods. All right, why is it not a male condom? Well, that's just a barrier method. There are no hormones involved there, obviously. So the fertility is actually unaffected there. What about the copper device, your IUD? So that's going to be a long-acting, non-hormonal treatment. And so fertility will return immediately after removal. C is our correct answer. Vaginal contraceptive ring. So that would be hormonal and reversible. Fertility would resume super rapidly after stopping that use. So that's why that's not the right answer. And fertility awareness methods, that does not suppress ovulation, right? So that's not it. She wants long-term contraception, and most options like IUD, vaginal ring, or even the barrier methods allow immediate return of fertility once it's stopped. And the one that's different is the progestin-only depot injection. That can cause delayed ovulation for up to 18 months after the last shot. And so this is asking, hey, what's the greatest delay in return to fertility? And the answer is going to be progestin-only injection. So the bottom line is progestin-only injection is associated with the greatest delay in return to fertility after discontinuation. And our next question, a 32-year-old woman visits the dermatology clinic with a persistent skin condition on her elbows and knees. On examination, there are well-demarcated erythematic plaques with adherent silvery scales. The patient mentions that her symptoms improve during the summer months as she spends more time outdoors. As part of her treatment plan, the dermatologist prescribes topical ointment along with advice to increase certain dietary components that might aid in the treatment. The effectiveness of this treatment suggests a biological role for which of the following vitamins in modulating keratinocyte activity and immune responses. So if your psoriasis gets better in the summer, then the reason is because you're making vitamin D. Here, there's a 32-year-old woman who has classic plaque psoriasis. It's thick, scaly plaques on the elbows and also the knees that improve with sunlight. And that's because of the UVB exposure that helps your skin produce vitamin D. And that in turn slows down the keratinocytes' overgrowth and it calms the immune system. So vitamin D is not just like a bone vitamin, right? It's a key immune modulator. So let's walk through why these answer choices are incorrect. So vitamin A for step 1, you should be thinking about acne and retinoid therapy because that can regulate skin turnover, but it's more associated with acne and epithelial stuff. B12, cobalamin, that's associated with megaloblastic anemia and neurologic symptoms. It's not involved in keratinocyte proliferation and immune suppression. Folic acid is involved in cell division and DNA synthesis. It's crucial in pregnancy and hematopoiesis, but it's not used in psoriasis therapy. And biotin, for step 1, you should think of the hair and the skin and the nails. And there's not any like autoimmune or keratinocyte regulation association there. So the bottom line here is psoriasis treatment highlights vitamin D's role in modulating keratinocyte activity and immune response. All right, in this question, we have a 24-year-old man of Korean descent presents to his university health clinic with complaints of palpitations and sweating after consuming a mixed drink at his friend's party. His parents' party. He reports that a similar symptom has occurred in the past after drinking alcohol, along with episodes of facial redness. Family history reveals his father experiences flushing as well. Which of the following enzymes is most likely associated with his symptoms? And before I show you all of these answers, I want to give you kind of the lay of the land here and try to answer this for yourself. So this Asian descent, this is Asian alcohol flushing syndrome, and this is involved in a genetic polymorphism that's common in East Asian populations. So Korean, Japanese, and Chinese predominantly. And the key metabolic pathway to understand is the ethanol metabolism, right? And so what we need to know is that ethanol turns into acetaldehyde via alcohol dehydrogenase. And then acetaldehyde turns into acetate via aldehyde dehydrogenase, which we call ALDH2. And when that is deficient or inactive, acetaldehyde builds up and it causes an unpleasant symptom shortly after alcohol ingestion. So flushing, palpitations, sweating, nausea, and headache, that kind of stuff. And so the facial redness, the flushing, the palpitations, the sweating after drinking alcohol, and especially in somebody of Korean descent with a family history of the same symptoms, all that leads us to think that there's some autosomal dominant inheritance pattern of ALDH2 variant of alcohol dehydrogenase, right? Because acetaldehyde is toxic. It's a toxic intermediate, and it causes vasodilation and also sympathetic activation. And so if somebody has East Asian descent, then up to 50% will carry that inactive ALDH2 allele. And so that's why our answer is D. So again, the pathophysiology is you drink alcohol, it turns into acetaldehyde or acetaldehyde. Then acetaldehyde via alcohol dehydrogenase is now just chilling, and then we can turn that into acetate via aldehyde dehydrogenase. But we have this deficiency in this patient, and so acetaldehyde accumulates, and that will trigger vasodilation, which is the flushing that you see. Geez, these words are like tongue twisters sometimes. But it's the flushing after the small alcohol doses in East Asians, and it's that ALDH2 deficiency, the facial redness, the tachycardia, the nausea, the dizziness. It's the failure to convert acetaldehyde into that harmless acetate. Now let's look at these quickly. Acetyl-CoA carboxylase, that's involved in the fatty acid synthesis, so it's unrelated to alcohol flushing. Succinate dehydrogenase, that's involved in the TCA cycle, complex 2 as well. So it's not involved in alcohol or aldehyde metabolism, so that's not the answer. Alcohol dehydrogenase, that converts ethanol to acetaldehyde, and that enzyme is intact. It's just the downstream with the acetaldehyde clearance. And xanthine oxidase, that's going to be in uric acid production and gout. So that's unrelated to the alcohol flushing and acetaldehyde buildup. So the bottom line here is that the alcohol flush reaction in Asians is often due to a deficient aldehyde dehydrogenase, leading to acetaldehyde accumulation. Hopefully you guys have enjoyed this video. If you have, please like and subscribe. More videos come out every single day. We've made over 860 videos. Stay tuned for a song that recapitulates all this information, and hopefully you guys have a great rest of your day. Take care of yourselves during dedicated period and enjoy this song.
Yeah. Yeah, a 10-year-old kid, chemo's on the scene. Wakes up in pain, uric acid mean. Tumor Lysis popping, pouring this breakdown. Kidney gets wrecked, crystals come round. This Endocarditis makes that acid rise. Watch out for gout and nephro that fries. Raspberry Kaizen, drop the uric fast. TLS management, built the last stash. 27 paranoid, won't leave the pad. Flat effect delusions is bad. Auditory vibes, hearing ghost talk. She's deep in psychosis, can't even walk. That positive and negative both in play. Chronic and strange, schizo all the way. Not just sad, not borderline mad. It's dopamine gone wild, brain gone bad.
Virus gets slick, drops MACI. Tryna hide from T cells, oh my. But natural killers don't need the code. If MHC low, they ready to explode. CD16 binds that opsonize game. Perforin, granzyme, a apoptotic flame. Innate on the rise, mutant can't hide. Parental strain, better run or die.
Tendon rupture, cal stays tight. 6 months later, calf ain't right. Disuse kicks in, muscle breaks down. Protein degradation takes the crown. Tumor pushing near the heart wall. Right atrium pressure, breathing stall. CT shows it's taking space. Who runs schizophrenic sets the pace. C35, keep you alive. Diaphragm's buddy, takes a dive. Forget the Vegas, forget the duck. Frantic nerves, the one that's stuck.
Yeah. Root canal done now, fever's high. Blowing murmur, bugs nearby. Alpha hemolysis, opto can resist that strep mitis. Can't be missed, the Pharynx native, now gone rogue. Damaged mitral valve, ascending cardio code. Post-dental, mitis, it's sly. Evidence crew makes that valve cry. 29, the career in mind. Once no kids got time to find. Low maintenance vibe, birth control queen. But Lee might mess the scene. Long acting, but may delay. Fertility bounce back, not the same day. Still safe and fine for most to choose. Just be aware before you cruise. Yeah.
Black switch scale on knees and arms. Sunlight helps, UV charms. Doctor says rub this D cream. Calcipotrine joins the team. Vitamin D binds nuclear code. Immune mod down, symptoms slow. Keratinocytes take the cue. Vessel 23, flare-ups few.
Wedding toast, champagne sip. Face turns red, heart starts to flip. East Asian roots, it's in the gene. AODH2 ain't keeping clean. I start to hide, builds up tight. Flush fast heart, not a pretty sight. Histamine dump, mast cells scream. Interference mimic, alcohol meme.